Today I'm going to discuss something about insulin titration, how to do insulin titration, and when. Before that, let me introduce myself. I am Dr. Hayat, endocrinologist from Srinagar, and I'm going to talk about insulin titration, how and when. Now, I will give you a case based scenario. Now, this is a patient who was diabetic 6 years duration. His BMI is 32 and his A1C is 8.7. And he has tried GLP-1 receptor agonists for diabetic control as well as for weight loss, but he has stopped treatment because he was not able to tolerate the drug because of GI side effects. And he was started with 10 units of glargine in the evening. Now, important questions about starting glargine and then titrating the dose of glargine. What are the what's the way forward, and what should be the HbA1c goal? Now, if you are using insulin glargine, whether you are using a device pen or a pre-filled syringe pen or a multi-dose vial, so you have to adjust the dose by 1 unit per day or by 2 to 4 units once or twice per week until the blood glucose reaches 80 to 130 milligrams per deciliter. If the fasting plasma glucose continues to remain more than 126, then the patient should contact his caregiver. And if there is hypoglycemia, like sugars are less than 70, the doses have to be reduced by 2 to 4 units or 10% of the total dose. Remember, if the hypoglycemia is a major hypoglycemia, that is blood glucose less than 40, and patient needs substantial help, that time the dose of insulin may be decreased by around about 30 to 40%. So for most patients with type 2 diabetes who are taking insulin, the glycemic goals we know are A1C less than 7 and fasting less than 130 in the absence of hypoglycemia. So once the patient has been started on basal insulin, has been initiated, and we are doing titration, at the same time, patient needs to know that technique of injection. And ideally, a diabetes educator nurse should demonstrate the way or the how to do the insulin injection, how to rotate the site of insulin injection, what are the methods of storage and transport required for insulin, and how to use a certified ISO 2013 glucometer, how to ideally the patient should be demonstrated how to use the glucometer, and hypoglycemia symptoms should be explained depending on the severity, what is level 1, level 2, or level 3 hypoglycemia, and accordingly the doses have to be titrated. And patients should also know their glycemic targets so that they can plan and titrate the insulin dosages, because you remember that diabetes care is almost 95% self-care, and the rest is up to the primary care provider. Now, other medications which the patients are taking, like which are glucose lowering medications, they have to be reviewed, and a follow-up has to be agreed between the patient and the doctor. Now, let me give you another example. Is 50-year-old male, diabetic, 6 years duration, is concerned about his uncontrolled diabetes. He has a weight gain and he's anxious and confused. His BMI is 29.2. His BP is normal, but his A1C is 8.6 with a fasting of 116 and postprandial of 210. He is on max doses of glimepiride, 4 milligrams, 2 grams of metformin, and 25 milligrams of empagliflozin. He has been started on glargine and presently is on 18 units of glargine at bedtime. So how to titrate his dosages, and how he should do exercise, and how he should consult a physician, diabetologist, or an endocrinologist, and a registered dietitian, and what should be the way up of titrating the dosages of insulin. So in range fasting plasma glucose with one or both, like if the postprandial sugars continue to remain more than 180 milligrams per deciliter, and A1C is above target. That means probably you need to make it basal plus or basal bolus. That means that that time the basal insulin is not proper entirely working, and the patient is also having postprandial hyperglycemia. Now, if the patient requires zero point 0.5 units per kg basal insulin during the day, and sugars are within range, that's fine. But if the dosages are higher, you would require more than zero point 0.5 units per kg of basal insulin. It strongly suggests that this patient is in need of a mealtime insulin. And further increase in basal insulin will cause either daytime or nighttime hypoglycemia. And perhaps that's the time to add this bolus insulin in this patient. So you can add a basal plus or a basal bolus depending on which meal time he is having high sugars. Now, let me give you another example. A diabetic patient, she's 15 years old and 15 years duration of diabetes and has been on insulin for the last 2 years, and a strong family history of CVD. And she's on 2 grams of metformin, 10 milligrams of DAPA, and 5 milligrams of linagliptin, and 60 milligrams of glycoside and glargine 32 units. And yet her A1C is 6.1 with a fasting of 168 and postprandial 230. So this patient, if you start increasing the basal insulin requirement, and the A1C is still 9%, post meal sugars are still high, and the requirement of basal insulin is more than zero point 0.5 units per kg per day. That's the time to add a rapid acting insulin analog in her current insulin regimen to achieve a proper glycemic target. So perhaps that's the time to stop titrating basal insulin and considering need for prandial insulin also. And so if your patient, to sum up, is not meeting the glycemic target on basal insulin, A1C is still high, even if you are giving zero point 0.7 to 1 units per kg per day of basal insulin. A1C is high despite a normal fasting, means fasting is controlled with basal insulin, but postprandial sugars are high, A1C is high because the contribution of fasting hyperglycemia towards A1C is 50%, and postprandial is almost 50%. We know that because we have a very high carbohydrate intake our diabetic patients across the length and breadth of the country. And if your fasting is well within the target, but postprandial is persistently high, A1C is high, or the need, as I said, of insulin is more than zero point 0.7 to 1 units per kg per day, perhaps that's the time to add this bolus insulin and stop titrating the basal insulin, because further increase in basal insulin will cause hypoglycemia. So how to do it? What's the algorithm for adding or intensifying insulin? So it depends whether you are seeing A1C or whether the patient is on one prandial. You want to add one prandial insulin before the largest meal. Say you are adding a zero point 0.1 units per kg or 10% of the basal dose at the largest meal, and then trying to see what's happening to sugars. And if the glycemic control goals are not met, you can add second dose of basal insulin, this bolus insulin. And the other way around would be to change to a pre-mixed insulin twice daily before breakfast and dinner. And you can divide the current basal dose into 2/3 in the morning and 1/3 in the evening. Or sometimes if the postprandial are too high, you can give half dose in the morning and half in the evening. And yet, if the glycemic goals are not met, then you can add one this bolus insulin before lunch. So you have to titrate the sugars every 2 to 3 days to reach the glycemic goal. And if there is you can increase the dosages of insulin by around about 10% after every 3 to 4 days or once in a week, so that you reach a pre-meal target of say less than 140 during lunch and during dinner. And if the chances of hypo are there and there is a decrease in sugars, which is drastic, then you can decrease these dosages of insulin by 10 to 20%. And if the patient requires substantial assistance for this hypoglycemia or the blood glucose is less than 40, at that time you can reduce the dosages of insulin by 20 to 40%. So the concept of basal intensification, as I said, if you are giving basal insulin and titrating and up titrating, and your glucose is nicely controlled, A1C is within target, and the requirement of basal insulin is less than zero point 0.5 units per kg per day, that's fine. But if your requirement of basal insulin is more than 5.5 units per kg per day, and your postprandial sugars continue to remain high, your A1C continues to remain high, that's the time to stop titrating basal insulin and intensifying it with a basal plus or a basal bolus insulin uh, therapy. So then the question would be how to store insulin in our patients who are using, like if you have unused glargine, you can keep it in the refrigerator and store it between 2 to 8 degrees Celsius. You do not have to freeze it, and if the insulin has been frozen, it has to be discarded, and direct light and heat exposure should be prevented. But once the multi-dose vial has been opened, it can be kept for 28 days at room temperature. There's no issue with that. So to conclude, I would say that timely basal insulin dose titration is very important to overcome clinical as well as patient inertia, and you have to take a detailed history to help out to figure out any error in the administration of insulin. You have to teach the patient how to use insulin pen or a device or a pen filled syringe. That use of glucometer has to be demonstrated. Hypoglycemia symptoms and signs have to be explained to the patient, how to manage those patient symptoms, and then a titration and up titration of basal insulin has to be taught to the patient. And if the titration up titration you fails, and you are not able to meet the targets, then you have to teach the patient what is the intensification of basal insulin therapy has to be stopped, and you have to add basal plus or a basal bolus insulin dose, or you can alternatively add two doses of pre-mixed insulin analogs for a better patient outcome as far as glycemia as is concerned. However, a patient continuous follow-up needs to be done for such patients. I think that should explain how to initiate basal insulin, how to up titrate, when to stop titration, when to add a pre-mixed two doses or a basal bolus or a basal plus therapy. Thank you very much.